of you remember Alexei Savtchenko. Alexei has done a number of things. He did his kinesiology and health sciences degree at York University in Ontario. He completed his internal medicine at the University of Toronto, and then saw the light and came west to do cardiology at Calgary. He finished his cardiology with us in 2022 and successfully passed his Royal College exam. He then went on to pursue training in echo at Mount Sinai back in Toronto, and he's presently at the University of Ottawa doing CT and nuclear cardiology. Now, I have a warning for all of you. If Alexei invites you for a tennis game, beware. He's won a number of provincial championships, and if I remember correctly, he was on the national team. So be very leery if he invites. Sorry, I was muted there. Once again, welcome everybody. We're happy for joining us this morning at Grand Rounds. We're very happy to have one of our own join us this morning, Alexei Savtchenko. Alexei has done a number of things. He did his kinesiology and health sciences degree at York University in Ontario. He completed his internal medicine residency at the University of Toronto, and then saw the light and came west to Calgary to do his cardiology. Alexei left us in 2022. He was successful at completing his Royal College exam in cardiology, and then moved back to Toronto to do echo at Mount Sinai. He's presently in Ottawa doing cardiac CT and nuclear cardiology at the University of Ottawa. Now, I have a warning for you all. If Alexei invites you to a tennis game, be very wary, okay? He's won a number of provincial championships, and if I remember correctly, he was on our national tennis team as well. So be careful if he invites you for a tennis game. Now, Alexei is going to talk to us this morning about stress testing in nuclear cardiology. As you can see, his title is Evaluation of Chest Pain and Testing Strategies. So Alexei, I'm going to turn it over to you. Thank you for joining us this morning. It's very nice to see you again.
Thank you, Dr. Kavanagh. Thank you for the warm introduction. And thank you to everybody at Libin for giving me the opportunity to present to you today. It's a pleasure to join everyone remotely today. You know, I certainly miss Calgary, and one of these days, you know, I'll hopefully get a chance to visit. You know, the selling factor as always is you know, the good skiing weather, the beautiful mountains, although I know how you feel about your residents and fellows skiing, Dr. Kavanagh.
As long as you don't break anything.
Yeah, that's always, you know, yeah, it's always a risk for sure. So today I'm going to be talking about evaluation of chest pain and testing strategies. So just to kind of start things off, in terms of chest pain itself, new or sudden chest pain, or those with accelerating patterns of chest pain, may necessitate urgent assessment in the emergency department to rule out life-threatening etiologies such as acute coronary syndrome, PE, or aortic syndrome. The investigation and management of acute chest pains have their own algorithms and workup strategies. But today, however, I'm going to be discussing and focusing on patients with chest pains of chronic and stable nature that is amendable to outpatient testing. So as we all know, the assessment of chest pain starts with thorough history, physical examination, and discussion of various risk factors to gather information about the clinical suspicion for coronary artery disease. As coronary artery disease remains a leading cause of death, and in developed countries, a misdiagnosis may lead to significant morbidity or mortality. Therefore, testing of the presence of CAD is often needed, but other chest pain etiologies should obviously be considered and investigated as well. So when we think about stable chest pain, there are things that need to be considered. Some of the key things that we need to consider are Number one, does the patient need any testing at all? And if so, what type of tests and what are the circumstances around those tests? And more specifically, whether the tests need to be anatomical or functional. And then once that decision is made, there's also a breakdown of the different types of functional tests. So I'm going to be going over these over the next few slides. So in terms of answering the first question about whether or not the patient needs testing in general, we rely on pretest probability of finding coronary artery disease. So in patients with suspected CAD, the pretest probability of finding underlying obstructive CAD can be approximated using the age, sex, and typicality of chest pain features. However, it's worth mentioning that the traditional pretest probability prediction tools were derived from invasive coronary angiography populations that no longer reflect the contemporary populations referred to non-invasive testing who have a lower prevalence of CAD. More contemporary pretest estimates have used lower risk populations referred for coronary computed tomography angiography. Furthermore, existing pretest probability calculators do not account for the varying array of less typical symptoms, nor do they account for the presence of cardiac risk factors. There is no wide consensus as to how the factors should be incorporated into diagnostic algorithms, but the presence of risk factors should definitely raise a red flag to a clinician for presence of CAD. So in terms of some changes to the recent guidelines. So the recent guidelines in 2021 from the AHA and ACC have suggested that low-risk individuals who are defined to have a pretest probability of under 15% have a low prevalence of obstructive CAD and may not require testing, whereas investigations are warranted in those with a pretest probability of more than 15%. Based on the suggestions from these guidelines, it is preferable to use contemporary estimates such as those published in the past 10 years, such as the one from the 2019 ASC guidelines, in preference to scores from historical patient series, which in themselves may overestimate the frequency of obstructive CAD. The recent AHA 2021 guidelines also mentioned that when available, information on the presence and amount of coronary artery calcium may be useful in enhancing the pretest probability of obstructive CAD. It is worth also mentioning that although a patient's pretest probability of CAD can be estimated using the above three variables, even current pretest probabilities have limitations. An example of such limitations is when we consider, for example, a 60-year-old woman with a history of diabetes, a current smoker, a previous history of CVA, and a family history of premature CAD, and her presenting with typical ischemic chest pains. And when we use some of these tables, we would give her a 16% pretest probability. When comparing her to a 50-year-old man with cardiac risk factors that are absent and with atypical chest pains, he would get a 17%. So you can kind of compare that, and therefore it's important to remember that guidelines do not provide all the answers. It's a great roadmap. However, it cannot replace clinical acumen. So an example of those two cases, obviously, the 60-year-old lady, just based on other clinical factors, will have more of a risk for developing coronary artery disease. Ultimately, the pretest probabilities for patients having disease and their associated categories of risk of major CAD events help us choosing the specific test method as exemplified on the slide. For example, those patients who are classified as intermediate risk with stable or, for that matter, acute chest pain can be evaluated both through anatomic and functional testing. The type of testing for these patients I chosen based on various factors that I will go into over the next few slides. So once we determine that testing is needed, the next question to address is what kind of test does the patient need? So when selecting the most appropriate cardiac test to investigate chest pain, several factors should be considered. In addition to test accuracy, patient-specific factors including contraindications to specific tests, previous known coronary artery disease or previous revascularization, as well as previous testing results and patient preference need to be taken into consideration. In addition, available modalities, as I mentioned, include anatomic and functional assessments, and each clinical scenario should guide appropriate test selection. Finally, the availability of newer imaging technology in terms of their hardware and software that enhances diagnostic accuracy should be considered. When there's uncertainty amongst modalities, the other factors to consider are availability, timeliness of access, and local expertise, as well as the costs. So before I move into the discussion about specific anatomical and functional tests, I want to go over some of the specifics of how we assess the accuracy from a statistical standpoint in terms of sensitivity, specificities, and various other methods that we use. So I guess some more of a non-exciting type of information, but I will try to keep this brief. In general, when we have a target population that we're looking at to test with a specific test, we compare such potential tests, including its performance, to the gold standard in terms of sensitivity, specificity, positive and negative predictive values, positive and negative likelihood ratios, and accuracy. This table serves as a reminder to us in terms of how to calculate the above-mentioned variables. In the interest of time, I will not be going over all of these equations here. But as an example, a measure of how well an index test does in terms of ruling out a certain disease, this is done through calculating sensitivity through a formula of true positives divided by false negatives plus true positives, and the negative likelihood ratio is also involved. Likewise, positive predictive value is calculated through the equation that you see on the slide there. And it's worth mentioning that a variable like a positive predictive value gives us an understanding of the probability of a patient of a positive or abnormal test result actually having the disease. This is another visual of a similar information as on the previous slide, with the additional concept of positive and negative likelihood ratio. So this is an important concept where the likelihood ratios measure the test's true ability to rule in a setting of a positive likelihood ratio or rule out in a setting of a negative likelihood ratio disease. And unlike predictive values, likelihood ratios is not affected by the prevalence of the disease. LRs are calculated by the formulas that you see at the bottom left-hand side of the slide. So generally speaking, as previously mentioned, sensitivity specificities reveal information about test performance. Predictive value reveal info about probability that test is correct for a given test result. It is dependent on prevalence. So for example, for women or females that are 10 to 30 years of age, they have a low positive predictive value and a high negative predictive value for breast cancer, versus an age group of 50 to 70 will have a high positive predictive value and a low negative predictive value for breast cancer. The likelihood ratios reveal information about the significance of the test results for an individual patient, as I previously mentioned. So when applied to medical testing, the Bayes theorem states that the probability of patient being ill or sick and testing positive is the product of likelihood that the patient tests positive, given that they're sick, and the pretest probability that they're sick. So to put it in a more simplistic way, Bayes' theorem indicates that the post-test probability of a patient's having or not having CAD is based on pre-test probability and the positive and the negative likelihood ratios respectively. Whereas I mentioned, the likelihood ratios measure the test's true ability to rule in or rule out disease. So this is an example of kind of application of the Bayes theorem is applied to stress echo, for example. So if the patient has a pre-test probability of a disease of 50%, their post-test probability of ruling in a disease based on the stress TTE with a positive likelihood ratio of 4.67 is 80%, as you can see there by the red arrow. Most commonly, we discuss various tests in relation to their sensitivities and specificities that are directly linked to the positive and negative likelihood ratios. Tests that is higher in sensitivity has a better chance of ruling out disease. You can see that if you were to plug in the higher sensitivity value into the negative likelihood ratio equation, this will give you a lower ratio value respectively. So higher sensitivity would lead to a smaller value in general. Tests that is higher in specificity helps to rule in the disease, and you can see that if we were to plug in a higher specificity value into the positive likelihood ratio equation, that will give you a higher value overall by reducing the value in the denominator. So that's an example of how a positive likelihood ratio would be higher by increasing the specificity. So now I will move on to discuss specific type of anatomic and functional testing that is available. As we know, anatomy and function is an evolving interaction. Anatomical tests include invasive coronary angiography, CT angiography, as well as coronary calcium CT. Functional tests include nuclear imaging, stress echo, and exercise ECG. Historically, coronary anatomy and luminal stenosis identified by invasive coronary artery angiography was used to guide revascularization. However, several trials over the last while, including the FAME trial, showed that anatomic stenosis does not consistently predict physiology. And more recently, practice has shifted on a pure anatomic assessment to one that includes functional assessment. So this is an example of imaging modalities that are used for evaluation of obstructive coronary artery disease and ischemia. This morning's focus will be on the non-invasive functional and anatomic modalities. So in terms of the anatomic modalities, as I say that, I just wanted to give a brief overview of invasive coronary angiography, which is, as you know, the gold standard test for detection of epicardial coronary artery disease. It is the most accurate assessment of presence and extent of epicardial coronary stenosis with a very good spatial and temporal resolution. And in stable coronary artery disease, it's typically reserved for patients with high-risk features on their non-invasive testing, those who have non-diagnostic findings on non-invasive testing, and unacceptable quality of life on medical therapy, such as those patients who have CCS class 2 to 4 angina despite medical therapy. ICA should not be routinely done for asymptomatic patients and those without high-risk features from a coronary artery disease standpoint, given that in those instances, the risks would outweigh the benefits. So another anatomical assessment tool is cardiac CT and coronary artery calcium. It is a ECG-gated non-contrast enhanced tomography used to assess the presence of coronary artery calcium. the absence of coronary artery calcium actually confers a very good cardiovascular prognosis with a 2.2% event rate at 10 years. The drawback of this is that with this pure calcium measurement, there's no ability to directly visualize the coronary lumen. Absence of coronary calcium also doesn't exclude non-calcified obstructive plaques in all patients. However, this test may be used in selective low-risk symptomatic patients. So next, I wanted to discuss coronary CT angiography, which has been making a decent amount of noise over the last little while, with it being pretty heavily represented in the 2021 AHA-ACC guidelines. CCTA is a non-invasive modality that directly images the coronary arteries and has now been, as I mentioned, endorsed as a first-line class 1 test by the societies, given that it has a very good sensitivity, up to 96%, with a very good negative predictive value. However, the drawback here is that its specificity on its own is relatively on the lower side compared to some of the other modalities, and it's around 82%. So in addition, CCTA is the only non-invasive modality that can detect non-obstructive coronary atherosclerosis and also assess for high-risk plaque features such as positive remodeling, low attenuation, and spotty calcification, which are associated with MACE events. In patients with previous revascularization, CCTA should be used very selectively, however. Caution should be used in imaging patients with documented CAD and those with previous percutaneous interventions, especially in those with multiple or small diameter stents, less than 3 millimeters, typically. CCTA can be used in patients with previous bypass, however, and is able to accurately assess for graft patency. But the assessment of the native coronary arteries in patients with previous bypass may be very difficult due to diffuse atherosclerosis. An example of effectiveness of CCTA was portrayed in the PROMISE trial in 2019, when CCTA was compared to functional imaging, and the results showed that there was a fewer false positive referrals for ICA with CCTA. Some other examples of studies that looked at positive value of CCTA is, for example, the Scott Hart trial as well. But given in the interest of time, I do want to cover all the modalities. I'm not going to go into the specifics of those studies, though. So this slide shows the previously mentioned high-risk plaque features of CTCA that has been previously shown to be related to MACE events. As you can see, that most of the high-risk features are unable to be picked up or readily picked up by other modalities, such as those who measure, myocardial blood flow or FFR. Those studies those modalities, are specifically designed to measure luminal stenosis, whereas the CTA can actually look into these high-risk plaque features specifically. So a few words about CT, FFR, and CT perfusion. Coronary CT angiography derived fraction of flow reserve provides assessment of lesion-specific ischemia with a similar sensitivity but greater specificity compared with a standard CCTA. Also, CT perfusion using vasodilator stress provides a good sensitivity and specificity for detection of obstructive CAD. It's not widely used, especially the CT perfusion as of yet. And my understanding is that the main drawback of it is the actual the extra radiation that's associated with it. And both FFRCT and CT perfusion may reduce the need for downstream coronary angiography testing, but there are limited data to support their impact on MACE, at least as of yet. So in terms of drawbacks, as I mentioned, the specificity is relatively on the lower side, although still pretty good. Image quality for CCTA is actually a lot of the time an issue, or should I say some of the time is an issue, in a setting of technical factors and patient factors, such as elevated BMI, as well as artifacts such as heavily calcified vessels causing blooming artifacts. Previous studies have suggested variable accuracy across studies and centers, and ideally CCTA should be performed in centers in which expertise is readily available. Another drawback of CCTA is the potential contraindications that include allergies to the contrast media, severe renal dysfunction, contraindication to some of the meds that we use with the protocol, such as beta blockers and nitroglycerin. As well as patient factors such as obviously if a patient is pregnant, if a patient is clinically unstable, or they're unable to follow commands such as breath holds. The incidence of intravenous contrast material induced nephropathy is low in patients with normal renal function, but is increased in patients with other comorbidities. And in terms of the radiation exposure, CCTA radiation exposure could vary depending on the protocol that's used. For example, prospective acquisition carries a much lower radiation dose compared to retrospective acquisition, and can be as low as less than 1 millisieverts actually. But typically the averages are 3 to 5 millisieverts, which is pretty comparable to other modalities, if not lower. So now I'll switch gears to the functional testing. So before I do that, however, I do want to remind everybody about the anatomy and physiology of coronary blood flow. As you know, we have epicardial arteries that are responsible for transport, prearterioles and arterioles that are responsible for regulation of blood flow, and capillaries that are responsible for exchange of blood and oxygen with the myocardium. To better understand the functional modalities, we need to remind ourselves about the ischemic cascade. The first thing that occurs in stress-induced ischemia, or ACS for that matter actually, are metabolic changes. So the myocardium preferentially uses glucose as an energy substrate. That's the first thing that happens, followed by a reduction in perfusion. With the next thing that happens is the diastolic dysfunction, followed by systolic dysfunction. Then ischemic changes on the ECG, followed by angina. The ischemic cascade explains why, with stress and PI, for example, we often times see perfusion abnormalities without significant ECG changes. And part of the reason why the sensitivity of ischemia being picked up on SPECT and PI is slightly higher than or significantly higher than stress ECG. So another look at the same thing, and as you can see here, you have the associated tests that are able to pick up abnormalities at the specific time of the ischemic cascade. So ischemia can be caused by both epicardial and microvascular etiologies, with epicardial mechanisms consisting of structural and functional mechanisms. An example of structural mechanism is that of obviously plaque erosion or rupture, versus a functional that could be caused by epicardial spasm. So microvascular mechanisms also can cause ischemias, and they're associated with structural functional mechanisms as well. Typically, functional mechanisms of microvascular ischemia include endothelial dysfunction, such as impaired vasodilation or enhanced vasoconstriction. And an example of a structural mechanism of microvascular mechanism of ischemia is that of, for example, vascular wall infiltration with amyloid. So functional tests for CAD involve the premise of provoking ischemia through increased myocardial work and oxygen demand. An example of this is an exercise MPI seen in this slide. Notice that when at rest, the blood flow, even through an atherosclerotic artery, is sufficient to supply enough oxygen to the myocardium that is leading to. However, myocardial ischemia is provoked during stress when the amount of blood flow through the diseased artery is insufficient to meet the higher O2 demand of the myocardium. This is due to the epicardial artery constriction at the stenotic segment in a setting of complete microvascular dilation. So we can detect ischemia through functional testing in the forms of ECG changes on exercise stress tests, regional wall motion abnormalities on stress echo and stress CMR, perfusion changes on SPECT MPI, PET MPI, contrast echo, and contrast CMR. Functional testing needs either an exercise stressor or pharmacological stressor. Both exercise and pharm agents can induce myocardial ischemia. Exercise is usually performed with a bike or treadmill, while pharm stress include vasodilator agents such as dipyridamole or dobutamine, for example. There are various advantages and disadvantages of exercise versus pharm stress. However, in the interest of time, I will not go over that in detail. However, it's worth mentioning that exercise provides hemodynamic data in addition to ECG findings, which can help further stratify patients. Exercise stress can also assist with such diagnoses as chronotropic incompetence, hypertension response, and exercise and low exercise capacity. So next, I'll go into some specific types of functional tests. So the first functional modality that I want to review is EST. So evaluation of stable CAD by exercise, EST has been around for many, many years. Such a longevity of this investigation is due to its relative simplicity, availability, low cost, and ease of correlation with patient symptoms. EST remains a valid strategy for investigation of chest pains, but has recently been downgraded to class 2 indication status with in the recent guidelines. Testing with EST in very low risk probability patients, those who have a pretest probability of less than 15%, is not advised because of the risk of false positive findings and the absence of meaningful changes between pretest and post-test likelihood with the study results. Some imaging modality experts actually mentioned this as one of the key limitations of the ischemia trial, that where there was a decent amount of people that were tested by EST that showed at least moderate to severe ischemia, leading to potential skewing of the results. The main disadvantage is the diagnostic accuracy, and this is the reason why they think that there's and so I would be in agreement with that. There might have been a bit of a flaw to the actual study design. So the sensitivity is 77 and the specificity is 68. So EST does not diagnose subclinical atherosclerosis. However, exercise capacity and blood pressure responses can be highlighted, and it could lead to reclassification of increased risk, although their management does not have consensus in the guidelines. Despite low diagnostic accuracy concerns, EST has retained utility in clinical practice, in part because of the prognostic value. This is achieved through scoring algorithms such as Duke's treadmill score, which combines ECG changes, exercise capacity, and the presence of chest pains. EST helps with functional imaging interpretation when other parameters might be considered low risk. So, for example, normal relative perfusion with a exercise MPI with a high-risk positive exercise treadmill test classifies an MPI study as abnormal, versus a low-risk and intermediate-risk Duke's treadmill score with normal perfusion classifies the exercise treadmill test as a false positive. And we oftentimes see this and evaluate it that way here in the lab. And obviously there's no associated radiation here. So next, I wanted to discuss stress echo, okay? So given its wide availability, safety, relatively low cost, and wide range of applications, stress echo has evolved into a central role in the assessment of patients with both suspected and known CAD. Stress echo combines transthoracic images with provocative stress protocols and records dynamic myocardial contractility in response to stress. It has good sensitivity and specificity for detecting ischemia. Protocols that are used are typically treadmill, bike, or farm protocols. It can be also used to diagnose other pathologies such as ischemic MR, assessment of diastolic dysfunction, as well as severity of aortic stenosis. The stress TTE, another advantage is that it incorporates resting images, which may identify other potential etiologies of chest pain, such as valvular heart disease, congenital heart disease, right ventricular dysfunction, pulmonary hypertension, or HCM. However, the drawback of stress echo is that oftentimes it's limited by large body habitus, resting regional wall motion abnormalities, and conduction abnormalities. So next, I will be going into a discussion in regards to SPECT. So globally, SPECT myocardial perfusion imaging remains one of the most common, widely available imaging modalities for the assessment of CAD. It has a high sensitivity and is able to assess myocardial perfusion, wall motion, as well as the LV ejection fraction. Therefore, it remains a class 1 indication for the diagnosis of CAD. As with other functional tests, SPECT should be considered in patients with intermediate to high pretest probability of CAD and in patients with established CAD or following revascularization. Exercise SPECT offers advantages over farm SPECT in terms of assessment, in terms of symptom assessment, image quality, functional capacity, and ischemic sensitivity. The specificity of SPECT has traditionally been a bit of an issue, however, has been improving. So gated SPECT images allows for an assessment of LV function, which is an important determinant of prognosis in coronary artery disease. Gated SPECT also helps to improve distinction between attenuation artifacts from myocardial ischemia or scar, and thus also helps to reduce false positives. The adoption of attenuation correction, CT, has reduced susceptibility to artifacts and false positive interpretation. In addition, I guess, the low dose CT also helps determine whether a patient has coronary artery calcium, which further improves specificity and refines risk. There have also been advances in regards to the detectors and the specific SPECT cameras. And the recently introduced CZT camera are more sensitive, more efficient, and have better energy resolution than previous sodium iodine crystal detectors. This has actually enabled a significant reduction in radiation dose, where traditionally, a SPECT study would would be associated with about as high as 20 millisieverts. Now, with the new cameras, the radiation dose is anywhere between 5 to 9 millisieverts. In addition to promoting low-dose imaging, solid-state SPECT cameras have also allowed for introduction of SPECT dynamic blood flow imaging and the measurement of myocardial blood flow, which may improve accuracy of SPECT and help identify patients with balanced ischemia, which is one of the dreaded drawbacks of SPECT. And it could also help with identifying patients with inadequate vasodilator response. SPECT, however, may be less useful for heavier patients as well as those who are more predisposed to radiation risk, such as pregnant population. This is a chart that I borrowed from one of my mentors here in Ottawa, Dr. Gary Small. I think he showed this at the CCC during one of his talks, and this just goes to show that there's definitely some advantages to SPECT, and discussing things with some of my mentors, there's definitely it's certainly not an obsolete or downtrending modality. As you can see here, it's even comparing to PET and CCTA, there's definitely some advantages. So next, I want to discuss positron emission tomography. PET-MPI is a powerful, well-validated technique for the assessment of patients with suspected clinically significant CAD. As opposed to SPECT, where a single photon or gamma ray is the main physical principle behind image generation and acquisition, in PET, a signal is actually generated through a physical principle of electron-positron annihilation, which is a process of an electron and positron colliding with each other, which ultimately produce energetic photons and gamma rays. These gamma rays disperse into an 180-degree angle to each other and are picked up by the processing units, which ultimately generate electrical signals, which is processed and constructed into an image in a more accurate way by simultaneous detection. So in terms of the latest AHA-ACC guidelines for chest pain include PET as a class 1 recommendation modality with high sensitivity and specificity, and a modality that provides significant prognostic value. The image acquisition with PET is typically through radio traces such as rubidium or ammonia, the two most commonly used traces in North America. It could be completed in about 30 minutes, enabling both patient convenience and rapid patient turnaround. Radiation exposure is also relatively low due to a short half-life of some of these radio traces and approximates 2 to 3 millisieverts per study. Although PET-MPI is first and foremost a functional modality, it should be noted that most modern PET systems are essentially a hybrid of PET and CT systems. These have multiple advantages, including fast, reliable attenuation correction and added ability to assess for the presence of coronary calcium. The greatest strength of PET, however, is its ability to quantify myocardial blood flow and myocardial flow reserve routinely and non-invasively with assistance from various software packages to facilitate this. Measurement of MBF and MFR improves accuracy in risk stratification and enables detection of microvascular disease, post-transplant vasculopathy, as well as balanced ischemia caused by multivessel obstructive CAD. Combined with other information, including calcium, LV function, PET and PI provides a very robust prognostication information. And some of the additive value of PET is actually, that it is given its the traces that are used and the KV that is generated compared to technetium. It could be used in heavier individuals with pretty clear images, as well as in patients who have attenuation material, such as ICDs in place. Sorry, 1 second here. One important limitation of PETs is that current PET radio traces have a very short half-life, and hence are challenging to combine with exercise stress. Thus, it is usually performed with pharmacological stress tests while patient is lying in the scanner. Exercise PET precludes the measurement of absolute blood flow as well. In patients in whom it is expected that diagnostic accuracy stress tests possible to assess for obstructive coronary artery disease, PET and PI may not be the best first choice of modality in that circumstance. However, this may change in the future with the introduction of longer half-life traces such as fluoripyridaz. Another group in which PET and PI may be less useful is those who are elderly, specifically over 85 years of age. And this is due to the fact that their life expectancy is likely lower than obviously for somebody who's younger. The availability of PET and PI remains limited in Canada. Although this is not a limitation of the modality itself, it remains an obstacle to widespread use. And finally, the initial costs of this modality certainly can be balanced out by the reduction of downstream testing and interventions. And then the other thing that could, balance out some of the expenses is that rubidium-82 generators are currently a fixed cost, and the cost effectiveness could be basically achieved by increased scanning in more patients. So next, I want to discuss CMR imaging. So as we know, it's a gold standard non-invasive imaging modality for myocardial function, quantification of volumes, and characterizing myocardial tissue, including scar. CMR offers a superior temporal and spatial resolution compared with other imaging modalities without the burden of acoustic windows, iodinated agents, or ionizing radiation. Stress CMR is an accurate and safe method to assess regional myocardial blood flow and is a class 1 recommendation modality for evaluating patients with stable chest pain in the latest guidelines. It has a very good diagnostic accuracy for detecting CAD. Multi-vessel disease sensitivity is 87% with a specificity of 73. Single vessel is 79 and 87 respectively. The positive predictive value is 91 and negative predictive value is 94 for the detection of significant CAD as defined by FFR. Importantly, stress CMR is less susceptible to false negative results when investigating balanced ischemia. Overall, the available data suggests that a negative stress CMR is associated with less than 1% annualized event rate and results in a low probability of unnecessary invasive coronary angiography. So, as we know, some of the drawbacks for CMR is its accessibility. The other drawbacks is that it's difficult to perform exercise-based perfusion in these settings. Patient can be claustrophobic, and given that they need to spend more time in the scanner, this may be a limitation. Implantable devices hinder image quality, although we do have some breakthroughs over the last several years that there's more device compatible, MRI compatible devices available. The renal dysfunction is no longer a barrier to administration of contrast material with newer microcyclic gadolinium-based contrast agents. So this is just a summary slide comparing the various modalities discussed in terms of their sensitivities and specificities. I do want to point out once again that, although traditional specificities are on the lower side, with an addition of gated SPECT as well as attenuation correction, and now with the flow capabilities, the specificity has certainly risen. This is another summary slide with outlining some of the advantages and disadvantages of various cardiac imaging modalities. I'll kind of let you look at it for a few seconds here, but an example of a disadvantage of CT angiography, as you see there, is that there's some the accuracy may be significantly affected with in patients with higher coronary calcification, and it obviously involves radiation, whereas exercise ECG doesn't involve radiation, but it's inferior compared to other diagnostic modalities, given the fact that it's low in accuracy and it's limited by baseline ECG abnormalities. So just finishing up here within the next couple minutes. Ultimately, from a general standpoint, in regards to stable coronary artery disease, to me, this is a useful table to remember when deciding between anatomical tests versus functional tests. However, as I have mentioned previously, clinical acumen is always needed for most appropriate testing determination, and there are multiple factors that play a role in such determination. In general, as you see from this table, for patients of intermediate to high risk who are younger, a CCTA approach is favored versus those who are intermediate to high risk who are over 65, a functional test is preferred. The other factors that have a role in choosing between the two are, as I've mentioned previously, availability and expertise, inconclusive previous study results, as well as additional indications for testing, such as anomalous coronary arteries or microvascular dysfunction. So this is just something that I showed previously, and the ultimate clinical question is whether we need to investigate for presence of any coronary artery disease versus an extent of an ischemia. Also, helps to determine which tests are used. The following two slides show more detailed decision algorithms for the type of testing based on the AHA 2021 chest pain guidelines. In the interest of time, I will not go over this in detail, but however, I do want to point out that this slide describes the evaluation of pain with a stable in a patient with stable chest pain with no known coronary artery disease. I do want to point out that, again, that for intermediate to high-risk patients with no known coronary artery disease, both CCTA and most functional tests that we discussed during this presentation are class 1 indication. Of note, the ECG stress test is a class 2A. This is an algorithm for patients with stable chest pain and known CAD. And as you can see there, after optimizing GDMT, if patients are still experiencing angina with no high-risk features, functional tests here are preferable for patients with CAD with known stenosis of over 50% with class 1 recommendations. And if there's a known stenosis of less than, or coronary artery disease of less than 50%, then CTCA is recommended as a class 2 recommendation. So in conclusion, cardiac test selection can be difficult and requires integration of patient factors, test accuracy considerations, contraindication consideration, as well as the strength and limitations of the different technology, as well as the local factors. Although developing algorithms and decision support tools may assist clinicians in selecting ideal strategies, there are potential limitations and limited, and these algorithms are limited by factors that cannot be well measured or quantified. So, despite the potential limitations, there are recently, here at the Heart Institute, Dr. Chow and his colleagues have actually developed a decision support tool for CAD testing. Basically, it's designed to identify the test options most appropriate for each individual patient scenario and to improve the diagnostic accuracy to minimize unnecessary downstream costs and testing or resource utilization. As you can see by the screening support tool, it's pretty comprehensive, and it incorporates variables such as demographics, patient symptoms, etc. But overall, the take-home point is that effective test selection algorithm should be individually tailored to each patient. As mentioned previously, anatomy and function is an evolving interaction. I thank you for listening. I know that I'm a bit over time, as usual, Dr. Kavanagh, apologies, but I'm happy to take any questions or learn from any of your valuable comments in relation to this topic.
Thanks, Alexei, very, very much. Very comprehensive presentation. Any questions? Rob, I see you've turned on your camera, so I think that means you have some comments or questions.
Yeah, I'm going to try to limit my comments, but just ask a broader question. So first of all, Alexei, thanks for that great review, great summary. If you were going to build a chest pain unit from scratch, where like outpatients came in with chest pain and you decide about testing, how would you decide which test for which patient, and like which modalities would you incorporate into that?
Yeah, thank you for the question, Dr. Miller. So, I would, so I'm a little bit biased here, given the fact that I know some of these algorithm breakdowns that I actually am involved in directly. As a fellow here at the Institute, we actually use, we've started to use these tools. So, ideally, in order, I guess, the way how would I would ideally set things up is that these type of screening tools would be used by, for example, a healthcare professional and who's screening the patient, not necessarily an MD, but it could also be used by a nurse practitioner, or even in some instances by an RN that could actually ask some of these patients to fill in information such as listed here. Then it would be processed. It would a specific test would actually be generated that's recommended for the specific patient. The patient will go on and actually have this test done, with the results of which is actually that would be available at their first consultation with a physician. At which point in time, decisions may be basically made in regards to further patient risk stratification and management planning. But to answer your question specifically, the two modalities that I favor is CCTA as well as PET perfusion. So these are the big guns right now in terms of non-invasive modality imaging, in terms of their great sensitivities and specificities, as well as some of the other valuable information in addition to coronary artery disease stratification that they offer. That I obviously didn't go into this with this presentation, but things such as inflammation assessment, as well as viability assessment with PET, we oftentimes use here in the institute.
Okay, thank you very much. We're at the top of the hour, so I think we'll have to call the question period now. But Alexei, thank you very much. And like I said, it's delightful to see you again. Thank you, everybody, for joining. Have a good.
Thank you very much. Good to see you and talk to you.
Okay, bye now.
Bye-bye.